Hello, everybody, and a warm welcome to you wherever you are in the world. I'm based in the UK today, as I usually am, and it is a very warm welcome here in the UK in the middle of summer. It's pretty warm. Phil, hello.
Hi, John. Good to be here.
Luke, hello.
Hi, John. Hi, Phil. Hi, everybody.
As you can see, Luke and I and Phil collaborated on our white color scheme today just to make sure we're fully branded. Today, Dr. Luke Moore is going to give us an insight webinar on AMR and CPE impact and interventions. I'm really looking forward to hearing what Luke has to say to us. But we were just chatting beforehand, actually, and I thought we might share some of that across the beginning of this webinar today about that AMR presents quite a unique challenge, even in the context of an acute hospital, in that it has quite a big reach across the hospital. Luke, I mean, be interesting if you expanded on that a bit.
Thanks very much, John. And yeah, so many of us who are in the field of infection, whether we're infection control nurses, infection control doctors, microbiologists, whatever your job role, it's very easy to fall into the trap of just thinking that antibiotic resistance is about managing the patient in front of you get through their infection, solve their UTI, solve their pneumonia, stop bug A spreading from patient A to patient B. But what we forget sometimes is the impact of that patient's antimicrobially resistant bacteria on the rest of their life and journey. So if they have cancer and need chemotherapy, what is the impact of that antimicrobial resistant bug on preventing them having chemotherapy? Sure, that will make them neutropenic, but will cure their cancer. What is the impact of that antimicrobial resistant bug on stopping them having some massive abdominal surgery to cut out something that needs cutting out if we can't cover them appropriately or treat them appropriately if and when they develop an infection? So I think it would behoove all of us, John, whatever discipline we're in, whatever area of infection we're in, just to remember that when we're helping our colleagues across the hospitals manage patients with antibiotic resistant bacteria, it's about the so what, the what if, the what's next when we're helping them get through that journey.
That discussion can be quite hard sometimes, because the so what, the what if often is measured in years and won't manifest, immediately. How do we address that?
Oh, that's a perennial question. It's been going on since C. diff, isn't it? So, so what if I give too many cephalosporins or too much Comox-Clav to my patient? And so what if they go on and get C. diff? Because each of these adverse events, should we call them that? Each of these adverse events are rare in the scheme of things, but when they occur, they can be disastrous for the patients, whether it's to have C. diff or whether it's to have such a carbapenem-resistant bacteria that they cannot safely have their bone marrow transplant or their bowlectomy or whatever it is. But I think it's our job to understand that these risks exist. It's our job to understand the proportionality of that risk, but it's also our job to relay that to experts in other fields, the surgeons or oncologists, the general medics, the intensivists. And it's only once we ourselves, everybody on this call, whether you're from the UK or Pakistan or South Africa, wherever you're from, to know the data and then be able to relay the data to those in which we work with. And John, you work here with me in the UK, and we're very much into the zone of intercalating our infection practice with all of the other disciplines. But as I've worked across the world, people speak less or more differently in between disciplines. So one of the pleas I'd give out is, please take away some of the data you learned today and feed it forward, relay it on to everybody you work with.
Okay, Luke, that's great. We could go on, but we won't, because otherwise we will run out of time before we get started. Let me just give a little bit of background to these Insight webinars to kick us off. So we're trying to provide an expert overview of a relevant topic, and we have Dr. Luke Moore with us today, who's a world-renowned expert. I'm going to make him blush now. We're keen to generate discussion So Luke will talk for around about half an hour, which will give us just under half an hour for Q&A. So do please put your questions into the Q&A box. It's important to put them into the Q&A box because that leaves the rest of the audience the ability to upvote them and to help us to filter the questions to put to Luke later. This webinar is CPD accredited, so you'll get a certificate of attendance afterwards. We want you to build critical thinking skills, so you don't take anything Luke says at face value, but actually analyze it, go away, work out whether it's real and whether it's real for you. And part of in doing so, we'll build confidence for your own independent research and study. We want to try and foster a network of enthusiasts and have a bit of fun. And just to let you know, these webinars are recorded and made available online after the event. So I'm going to stop sharing and hand over to Luke to speak to us on AMR and CPE impact and interventions.
Thank you very much indeed, John and Phil, and thank you for inviting me to speak here today. And it's a pleasure to be joined with so many of you from so many different professions and from across the world. And I know that you're a mixed audience of infection control nurses, infection control doctors, infection control practitioners, microbiologists. We've got everybody here today. And so I'm going to try and walk that narrow line of finding something across my 25 minutes-ish of monologue that's interesting to each of you. But bear with me if I go too deep into the microbiology or too deep into some aspects, because it will resonate with some of the rest of you online. Now, before we go any further, I have some disclaimers, and I would invite you to draw your eyes down the list of public sector and private sector grants in which I'm in receipt of, but none of it should particularly influence what I'm about to say today. I want to cover two main areas. First of all, I want to remind us all of the problem, where we are with AMR. And then I want to think of the four main tools that are in the armamentarium of each and every one of us to address antimicrobial resistance. And that's stopping it spreading through IPC, managing the patient in front of us through antimicrobials, identifying that patient in the first place through diagnostics, and then helping the wider healthcare profession understand how we can move forward with antimicrobial resistance through education. And as John alluded to, I am sat here in sunny old United Kingdom, but I have joined many of you from across the world in your different respective areas of practice to see how things work where you are. Not all 206 countries in the world, but I try. So when we open up to the Q&A, please do ask me how what I am saying today may or may not resonate with you, because that's where the interesting things are, right? Now, as gross as it may seem, and I know you know this, but it's worth just starting right at the beginning. As gross as it may seem, there are approximately 10 trillion Luke cells in me right now, human cells in me. But there's also approximately 1 to 1, 10 trillion bacterial cells on me and in me, on my skin, in my hair, up my nose, between my mouth and my anus, just sat there doing absolutely nothing at all. And as you know, many of those bacteria have names which send shivers down the spines of many of us. E. coli, Staph aureus. Hey, I'm a healthcare worker. I might even be colonized with MRSA. I work in the UK, so I might not have Acinetobacter baumannii, but I may do. And within my intestines, these E. colis and Klebs that sit with me, well, I'm a carnivore. I eat barbecues. I eat undercooked meat sometimes, maybe some of my bacteria, some of my E. coli's harbor antimicrobial resistance genes, but I am fit and well. And that's often a problem when we try and communicate with patients in front of us and colleagues in our wider healthcare environments about trying to understand that difference between antibiotic resistance is a thing that bacteria have, not humans, and that antibiotic resistance is a thing that is heterogeneous and spread through different bacteria to different degrees, but that all of that can mean nothing at all. It can just mean that your patient is colonized with no harm until and unless something happens, chemotherapy, an incision, an explosion of your intestines, a UTI. But as you and I know, the bacteria in each and every one of us right now are promiscuous, and they share their genes with each other with alacrity, meaning that if you have one strain of bacteria in your intestines right now that harbors an antibiotic resistance gene, it can share it with other bacteria in the same species. It can share it with other bacteria not even in the same species. So an E. coli that harbors a carbapenem resistance gene can spread it to a Klebsiella or Citrobacter and Enterobacter, and so on and so on. But when we think about why we're in this pickle as humanity, we have to think about what the drivers are for causing our global pandemic, and I don't use that word lightly, the global pandemic that is antimicrobial resistance. And when we think about that, there are several different moving pieces there, right? You could say, well, it's because we're not vaccinating appropriately, or because we don't have the right diagnostics, or because we flush antibiotics down the toilet into our sewage system, or because lots of people travel, or because we put sick people in hospitals next to each other. You could say all of those things, or you could say it's because we are suboptimally overusing or misusing antibiotics in humans or animals. But actually, it's probably a little bit of all of that, isn't it? But in saying it's a little bit of all of that, it's not the same weighting. So when you think about the relative contribution of each of those factors, and when you think about the evidence behind each of those factors, and when you think about the proportion of humanity for whom that factor is a driver towards AMR, then probably it is that over and misuse of antimicrobials in humans and in animals, which are the two big money, big ticket items for driving AMR. So that brings us, so now you understand the causes, that brings us to where are we now in the mid-2020s? Well, for the last, I don't know, 30 years, since I tutored off to university and learnt how to spell E. coli poorly, we've known that E. coli can pick up resistance to cephalosporins and Comox-Clav, right? And we've named them extended spectrum beta-lactamase producers. And we know that over the last 30 years, the penetrance of those resistant bacteria in each of our different geographic areas varies, and you can portray beautiful maps about that. That has meant over time that we have reached further into our antimicrobial cupboards and brought out carbapenems, and that in turn, bearing in mind that each of these bacteria reproduce every 20 minutes, compare and contrast to us who reproduce what, every 20, 25 years, 30 years, has brought about carbapenem resistance. Now, to the left of your screen here, if you look at the raw data of where we're up to with carbapenem resistant Klebsiella pneumoniae, you can see how much of the high income countries in the world still have quite low resistance rates to carbapenems, what, less than 5%. Again, sticking with the map on the left-hand side of your screen, if you look at the raw data, then you can kind of see how some areas of the world, and here I'm looking a lot towards West Africa, perhaps even more so towards South Asia, you can see how there is a huge weighting towards carbapenem resistance there. What I'd like to do, though, is to draw your eye down to the bottom right-hand map, which is not the raw data, it's what we think the data should be, allowing for the fact that no data is accurate, allowing for the fact that only some patients present to hospital, and then only some of those will have a test that can diagnose a carbapenem-resistant bacteria. But this isn't just true of the bugs that are sitting in your bowels and my bowels right now, these E. colis and Klebsiellas. It's true of lots of other bugs. But when these E. colis and these Klebsiellas get out of our intestines and cause a UTI with a bacteremia, or you have, I don't know, appendicitis, and you have peritonitis and a bacteremia, then the extent of the antimicrobial resistance of that bug has a direct impact upon your mortality from that problem. And here, in this study that looked at multiple different ICUs across Europe, what they found was that if you have a bacteremia with a carbapenem susceptible E. coli or Klebsiella, your risk of death is 8%. And that kind of resonates with me. It might resonate with you. So if you come in with somebody with a urosepsis or an abdominal sepsis, and you can give them a carbapenem, even if it's an ESBL, then what, 1 in 12 die. But look at that tripling in mortality rates from CREs where you can't use a carbapenem, where you've proven your E. coli or your Klebsiella is resistant to a carbapenem, then really that's the writing on the wall for the patients who are coming in just with this problem alone, with this carbapenem resistant bloodstream infection. A moment ago, I noted how CREs, and John and Phil, we might want to pick up the hole we've all dug for ourselves with the confusing three-letter mnemonics in this area. Not only are we facing CREs, carbapenem-resistant Enterobacterales, but amongst wider carbapenem-resistant organisms, we also face, let's start with Pseudomonas, right? Each and every one of us on the call will have, I'm hoping, particularly in the UK where it's hot and sweaty, had a shower this morning, and we all will have showered in Pseudomonas. Every time you pick up a glass of water and drink it, you'll be drinking Pseudomonas. Depending upon where you live, your strain of Pseudomonas has a greater or lesser chance of being carbapenem resistant, and yet you're inoculating yourself or your intestines with it every time you come into contact with water. And of course, not just CREs demonstrate increased mortality in the patients we serve, but carbapenem-resistant Pseudomonas demonstrates increased mortality. Here you can see how 30 or 90-day mortality is manifold higher than susceptible Pseudomonas. So we're looking at 40% 90-day mortality where you have a carbapenem-resistant Pseudomonas aeruginosa. Some of you are in even warmer areas of the world than where I'm sitting now, and there you may be struggling with Acinetobacter baumannii, an environmental gram-negative organism that we fortunately, touch wood, do not see much of here in the United Kingdom, but where we do, it causes just as much chaos with us as it does with you. And the resistance rates to carbapenems amongst Acinetobacter baumannii are eye-wateringly high, as is the mortality from CRAB. And I was talking before about what 24% of patients with CREs die, 40% of patients with carbapenem-resistant Pseudomonas aeruginosa die. Look here to this mortality for carbapenem-resistant Acinetobacter baumannii. We've got what, 70% of people dying from a bloodstream infection with a crab? Sobering stuff. But what about change over time? Because none of these maps, which are paraded by me and others, are dynamic over time. And of course, we all know that everything changes over time. Movement of humans changes over time. Movement of bacteria changes over time. Likelihood of seeking healthcare changes over time. Likelihood of being able to obtain and complete a course of an antimicrobial changes over time. So when we look at the resistance rates over time, we see for carbapenem-resistant Acinetobacter baumannii, proportions are approximately the same, but look to North America, 50% increase in 5 years. In carbapenem-resistant Pseudomonas aeruginosa, what you're seeing is dynamic changes, and John and Phil are far better than me at the built environment, and I wonder if some of that fluctuations in time for carbapenem-resistant Pseudomonas aeruginosa is to do with the way in which our healthcare facilities are changing over time. But depressingly, look at CREs, and even more depressingly, look at some areas of the world, these WHO regions such as Middle East and North Africa and South and Central America, where the CRE rates are not just doubling, not just tripling, but sanctupling. John will correct my grammar later. And so what we're seeing now is a real threat towards the bastion that's been carbapenem prescriptions in managing patients with gram-negative sepsis. Not only, though, are there dynamic changes in rates over time, but we cannot really believe the data which each of our governments portray. And Scott Pallett, one of my PhD fellows, has looked at this in some detail and compared and contrasted the different observatories in different regions of the world, including WHO, ECDC, and so on, to say, look, are you guys recording the same data about what proportion of bugs in your countries are resistant to any given drug? And the answer is no. In Europe, we're quite aligned. to what WHO thinks the rates are, but that's not that accurate. But look to the rest of the world. You've got huge variation in the proportions of resistance any one country is offering up to WHO versus offering up to Atlas versus offering up to their regional observatories. So our ability to delineate what resistance rates or CRE rates in any of our countries are is less than we wish. And not only that, confusion in rates, but also there is a confusion or heterogeneity in the underlying resistance mechanisms, meaning that in different areas of the world, if you rewind maybe 10, 15 years, you could draw pretty clear geographic regions about what type of CRE resistance gene was likely to be causing a carbapenem resistant E. coli in your patient, given which area of the world they were in. Fast forward to now, particularly in cosmopolitan cities the world over, but particularly here in London and all of the big urban conurbations, what we see is a complete loss of that ability to apply any kind of epidemiological history to predicting the underlying molecular mechanism resistance underneath a carbapenem resistant gram-negative, meaning that a patient can come into my emergency department in London from South Asia. And historically, I might have been able to say, well, you've got a pretty high likelihood of a metallobutyllactamase probably going to be an NDM. Now I can't predict that. Historically, I could have said, oh, my patient's coming to me from the Middle East, and I could have had a pretty high likelihood of having an OXA48. Now I can't predict that. So you've got heterogeneic rates of resistance between countries. You've got heterogeneity in the temporal dynamism of those resistance rates. They change over time. You've got an inability to accurately record CRE rates in each country. And just delineating a CRE is itself more complicated by the fact there's different genes underneath them, which leaves us all in a really sticky pickle, doesn't it? And if you wanted to add even more salt to the wound, don't do that. If you wanted to add even more salt, you would say, well, what about the impact of conflict and catastrophe on the world? And John and Phil, we might pick that up after, but with the forced displacement of humans within countries and out with countries, that's compounding the issue. And I think when we think about the impact of geopolitical flux, for those of you who want some after dinner reading, the top right one in Nature Medicine that I co-authored with some colleagues from around the world, it really is sobering to think about how we as humanity are potentiating AMR through our inability to get on with each other. Anyway, you know the problem, you knew the problem, now you know the problem in more detail. Feel free to promulgate that data to surgeons, oncologists, hematologists, intensivists, and every other healthcare professional you sit with. So what are we going to do about it? Well, I outlined earlier that there are four main tools that sit in the armory of each of us, right? And that's stop the problem spreading from patient A to patient B, do some kind of infection prevention control. Treat the patient in front of you, some kind of antimicrobial therapy. Diagnose things better and educate everybody. They're the four main tools we all have. So let's work through those. So when we talk about infection prevention control here in the UK, and I know that many of you practice in other areas of the world, but here in the UK, we have something called the National Infection Prevention Control Manual, which is a weighty tome of data and policies and protocols for how to manage different infection prevention control things. But if you, rather boringly, over a rather large cup of tea, wade through to Appendix 11, it has a nice synopsis of how you can start to pull all of the evidence together around IPC precautions for patients with carbapenem-resistant organisms. And when you look at the big three carbapenem-resistant organism groups, Acinetobacter baumannii, CREs, and Pseudomonas aeruginosa, you can start to see some similarities, right? Sure, the types of diseases they cause are slightly different, but actually you need to be thinking about at least contact precautions, for each of those things. And with Pseudomonas aeruginosa, you also need to be thinking, particularly if they have pneumonia, about the potential for droplet spread. You need to be isolating these patients. Really easy for me to say, but I'm a pragmatist, and I understand it's really hard to do, to put these individuals inside rooms in busy healthcare environments. With perhaps the exception of the droplets in carbapenem-resistant Pseudomonas aeruginosa, there is no requirement for respiratory protection. These things do not fly, unlike the aerosolized viruses that many of us have fought with over the last 6 years. And depending upon which country you work in, there may or may not be notifiable regulations. Fortunately, we are moving in that direction in the UK. But really the mainstay, right? The mainstay for patients with carbapenem-resistant organisms is just do the right thing. Do the right thing and wash your hands. And I was talking to one of my colleagues in my office earlier today, and she was saying they just need to wash their hands, don't they? And she is 100% right. But the problem with the 5 moments of hand hygiene that WHO promulgates is not it's technically difficult to conceptualize. You and I both have this figure printed out in all of our offices, in all of our emergency departments. The problem with patients with carbapenem-resistant organisms is that they're usually quite sick. They usually need a lot of scans doing. They usually have lots of different staff members coming in to consult. They usually have multiple comorbidities. They usually have lots of devices in, and they're usually on lots of different antibiotics, which will be being hung up at different times of the day and thrown into sluices and brought out from sterile units. So going from a rather simple 5 moments of hand hygiene to being able to have concordance to the 5 moments of hand hygiene throughout each of these very complex days that these patients are in hospital. That's where the biggest bang for our buck lies, right? If we're going to seriously think about IPC CREs. For those of you online who are prescribers, and that may be a minority of you, but for those of you online who are prescribers, you will be very comfortable over the decades of your careers with fairly standard beta-lactam antibiotics, right? And you'll all understand that they don't treat different things. And if you draw your eye along the row that says carbapenem-resistant Enterobacterales, the CREs, you'll understand that none of these things work. Fortunately, to greater and lesser degrees, the pharmaceutical industry have responded to a certain degree to this existential threat to humanity and brought to the floor various different molecules which have various different levels of activity against these resistant gram-negatives. The problem I face is not in pronouncing these molecules, although some of the colleagues which you and I both work with will be unable to pronounce these things. The problem I have is trying to identify which molecules work for which patients with which bacteria. And that is hard enough in a reasonably well-resourced setting in London in the United Kingdom. But I really do get that it's hard to do that elsewhere. And although we understand the risk factors which predispose our patients to harboring carbapenem-resistant organisms, we can write these down, right? These are the big 9, you can write them down. But you can't ever really put these as a tick box exercise in your emergency department and say, oh, if your patients meet X number of these 9 things, then they're likely to have a CRE, so please put them in the side room, burn their clothes and chuck away the key. You can't really say that, because although these 9 risk factors are likely to varying degrees to mean your patients at an increased risk, none of them is pathognomonic. None of them is absolute. So if we're going to be absolute about identifying which patient has a carbapenem-resistant Enterobacterales, meaning that we can do the IPC intervention and we can give them the right drug, then really, this is where I'm going to get on my hobby horse for a moment, so do excuse me, really we need to focus on diagnostics. And when we think about the kind of infection journey of any patient, right, we can start to put decision nodes in that patient's journey, can't we? We can start to say, well, they come in and they've got some kind of syndrome, pneumonia, UTI, skin and skin structure infection, whatever. And we can start to come up with some kind of empiric treatment. Please have some Comox-Clav. Please have a cephalosporin. and we can send off some tests, and then we can get those tests back and we can give them some targeted therapy. And then we can say, oh, your kidney function is not optimal, or oh, your albumin is not optimal. And we can fiddle around with that and we can individualize that. And then hopefully they get better and we can stop all the antibiotic nonsense and they can go off and go to the cinema and go to the supermarket. But when we look at the different types of components that feed into each of those decision nodes, we can start to understand how a lot of those data points are tests. And those tests fall into different buckets, don't they? Rapid diagnostics, culturing stuff, biomarkers. But across all of this, the problem you and I face in each of our areas of practice is that many of the key tests are at the targeted therapy point in the patient's journey. And what we need to do is move everything to the left so that each of these tests, whether they're biomarkers to say whether the patient has an infection or not, or whether they're a rapid diagnostic to say whether the patient has flu or not, or COVID or not, or whether they're a susceptibility test to say the cause of this person's urosepsis is an E. coli, and the cause of this person's E. coli urosepsis is a carbapenem-resistant E. coli. We've got to move all of that to the left of the screen. The problem I have, though, here in the UK, is that still our national guidelines, this is a direct screen grab from our national guidelines about how to diagnose a carbapenem-resistant organism. Many of our national guidance are still based upon outdated diagnostic methodologies. So look here, we see that our current guideline says, do your rapid tests, rapid in inverted commas, do your tests, be they molecular or enzymatic, to detect carbapenem resistance. Once you've grown a bug, and way down at the bottom right have that chart. But then if you look at the optional bit, certainly in 2022 when these guidelines were last revised in the UK, it says optionally you might want to do some kind of molecular detection test for carbapenem resistance right off the bat. You might want to. It's optional, right? The problem is that that's when you give humans options, when you give health systems options, they often choose the most economically viable option rather than doing the right thing. And if you fast forward to now, then Scott Pallett, my aforementioned PhD candidate, we won't get into him too much because he makes me feel inferior. But one of the things Scott Pallett has done is to cross Greenland and cross Antarctica, where he has applied rapid molecular diagnostics for a few pounds at a time in ultra remote environments to diagnose CPEs, CREs. So if Scott can trek across Antarctic and diagnose CREs using rapid molecular diagnostics for a few pounds, then why can't we do it in some areas of the United Kingdom, in Pakistan, in Egypt? The technology is not now the problem. The technology is not now the problem. Adoption is the problem. And when we look at this is work that Georgia Lamb did under my tutelage just recently, just published in CID, when we look at the government's drive, incentives to adopt diagnostics for managing the threat that is CREs, we see, yay, most countries who've got a national strategy for AMR have said, yeah, diagnostics are super important. The problem is that most countries, most of the 206 countries in the world, are saying, look, we still need to grow stuff. We need to culture stuff in order to be able to identify which of our patients harbor antibiotic resistant pathogens and manage them appropriately. And many fewer are understanding the need to focus on point of care diagnostics or molecular diagnostics. And where governments are not focusing on point of care diagnostics or molecular diagnostics, there's not going to be any governmental funding for healthcare providers to focus on those aspects. And the last thing, of course, which all of us can do, and it's partly about what today's about, but it needs to be promulgated onwards, is education. And here in the UK, just as an example, for our undergraduate courses, as a doctor in the UK, you've got to receive 5,500 hours of undergraduate education to be defined as a doctor and pass some tests, but yeah, that's small print. 10 years ago, when we looked at how much of the 5,500 hours of undergraduate education that a doctor receives is something to do with antibiotics, the answer was 17 and a bit hours. out of 5,500. When we redid this just this year, rather than increasing the amount of education we're giving our undergraduate medics to think about antibiotics, we've more than halved the amount of education we're giving. Similarly for our postgraduates, again, UK data, apologies for that. When we think about when we are accrediting our consultants in the UK, so the curricula they follow to become a consultant in genitourinary medicine, or a consultant in gastroenterology, or a consultant in endocrinology, or a consultant in surgery, so on and so on and so on. Far less than 1% of each of their curricula is anything at all to do with antibiotics. And yet, I would argue, one of the most common drugs for a surgeon to prescribe, picking a random example, would be an antibiotic. So we've got a long way to go. So I'm hoping, John and Phil, that I haven't painted too bleak a picture in reminding us all about how we share one-to-one for each human cell we have a bacteria cell, and that these bacteria may or may not harbor antimicrobial resistance, and it may or may not cause each of us a problem, but that degree of antibiotic resistance that any of us can harbor varies by geography, varies over time, varies depending upon the food and drink we eat, varies in its reliability dependent upon our observatories, and varies depending upon how much our societies have been impacted by conflict and catastrophe, and that will vary across the globe. And I hope I've given you a little snippet of hope in the 4 tools that we have, but actually they're just the same 4 tools we've always had. Stop bugs from spreading from patient A to patient B, treat the patient in front of you, diagnose what the problem is, and educate everybody. I'm going to shut up now, John. And as you said in your preamble, we'll get to the most interesting part, which is the Q&A.
Thanks, Luke. Brilliantly done, and an amazing insight into what is a real challenge for all of us working within healthcare. I couldn't agree more with the tools that you summarised at the end about what we have available to us, and thinking about the role of diagnostics. And of course, prevention is much better than cure if we don't have any cure at the end of it as well. We've got a lot of questions, Luke, so John and I are going to alternate. There was one which really took my eye straight away. And this is from Catherine. I don't know if you'll be able to answer this. It's something that's even been out there in the literature, but we obviously got different mechanisms for carbapenem resistance. And Catherine asks whether or not the mechanism of resistance, i.e. the genetic mechanism, has any impact on mortality. So if you've got, a patient with a plasmid carrying carbapenem resistant gene, is that different to one on a transposon, or do you know about that?
So I would argue where the gene is held, plasmid versus chromosomal, probably not, although I'm just going to put a pin in that, because in some of our data coming out of the Ukraine-Russia conflict, we've seen a movement of some resistance genes, particularly OX48, from plasmids into the chromosomes of Klebsiella. And, well, full stop. Point number 2, they appear to be more virulent. Now, it was quite important that I put a full stop there, because I cannot relate those 2 things as being cause and effect, but they are 2 independent observations that we're trying to get to the bottom of. So does integration of a resistance cassette from a plasmid into a chromosome manifestly change the virulence of that bug? Don't think so, but we just need to unpick why some strains are more. I suspect, this is a hypothesis, is that lots of plasmids are quite greedy, and they'll have not just a resistance gene, but also elsewhere along they'll have cassettes for virulence, and they might move en masse from the plasmid to the chromosome. And of course, once those different cassettes are moved from plasmid to chromosome, they can then leverage the wider machinery of the cell in which they're in, right?
Makes sense. And it's quite frightening from an evolution perspective, that is, isn't it?
Isn't it?
Taking up all these characteristics around virulence and persistence and infection to be able to cause more problems for us.
Okay, good question. Interesting start. I read a paper fairly recently from Italy that showed that infection with a metallo-beta-lactamase carbapenemase had a poorer outcome in terms of mortality than other carbapenemases. So there is some data that differences in the type of carbapenemase you have, perhaps within the bacterial genetic background, are significant in terms of outcome.
Yeah, and I've read that paper too, John. The question for anyone in this global group in front of us, the question for anyone who is fast and good at trials is, what I want to see is direct propensity matched studies looking at patients with a metallo-beta-lactamase E. coli infection versus patients with a serine beta-lactamase infection, who both receive the right antibiotic at time 0. Because I think there's a bit of ascertainment bias there, in that the metallos have higher mortality, sure, but that's because we're giving some kind of antibiotic to start with that may have some activity against serine beta-lactamase but then it's just that next step, isn't it, to go to the antibiotic cupboard to reach an antibiotic that has activity against the metallo. So they get their antibiotics later on in their journey and their progression towards severity. So that's why the mortality is higher. But
okay, now Jill has presented you with a nice catch-22, Luke, with a question around hand washing, which you put forward as perhaps the single most important intervention to reduce the risk of spread. But what if your water supply or your water outlet is contaminated with CPE, Pseudomonas, or another significant organism?
Yeah, so it's very easy for me to sit here in the United Kingdom, where we have health technical memorandum and health building notices coming out of our eyeballs, and we have water monitoring systems in our healthcare environments, and we send off water for sampling for various different things at various different augmented care levels to monitor for this. But as I've said before, I'm a pragmatist, and I've worked in many areas of the world where you just turn on the blinking tap and you do your best. So what does that look like? Why do we wash our hands with water and soap? Why? Well, there's a couple of reasons, isn't there? The first reason we wash our hands with water and soap is if they're obviously dirty and there is biological residue on our hands. That's reason one. Reason two is where we're worried about an organism that does not have an outer layer for which alcohol would work, meaning norovirus or C. diff or something like that. But that's not CPEs. So in a setting where you are worried about water coming out of your hand washing faucet, I would argue a very simple way to overcome this issue is wash your hands with soap and water in the water faucet. If that'll get rid of the biological residue. If in doing this, they become inoculated with CREs or carbapenem-resistant Pseudomonas coming out of the water faucet, okay, all right, I've got rid of the biological residue. Now I'm going to use some alcohol. And yes, it doesn't kill noro, and yes, it doesn't kill C. diff, but it kills CPEs. So get rid of the biological residue, bit of alcohol gel, done.
Thanks, Luke. There's a question here which is actually generating quite a bit of debate between people online, which is around about screening. So do you think we should screen patients admitted from acute hospitals moving forward rather than the guidance of London, Liverpool, Manchester, etc.? David, I think he says, gets pushed back in my organisation when I recommend screening all patients from a hospital just outside London, but I feel it too important to ignore. What do you think?
Well, John, and I don't want to reopen the wounds from our journal club, John, where we had a disagreement about screening for CPEs. But look, and I'm aware that, as I said, lots of you online are from different areas of the world. But here in the UK, we have a national guidance document that was put out in 2021 by our National Health Security Agency. And in one of the appendices, you can tell I'm a geek, I love reading appendices. In one of the appendices, it had four area scoring system called RISK, R-I-S-K, that basically said, have you been anywhere where there's a high level of CPEs? Have you had any antibiotics recently? Have you had any of this set number of procedures recently? Or have you been known yourself to have a CPE before? Now, that's, to my mind, the minimum viable trigger. And I think, to be honest, I'm not just trying to blow smoke up the bottom of the UK HSA here. I do believe that is a minimum risk factors that should be flagged in an emergency department, and if your patient meets those 4 criteria, they should have a screening sample. Lots of other places go broader than that and say, oh, well, okay, I get that that's a minimum viable product. I'm going to screen anyone who's been abroad. And this is where John and I disagree. Or I'm going to screen anyone who has been into any hospital or any healthcare organization, even if they haven't got an outbreak of CPEs in that hospital. And, or you might want to say, actually, I'm not going to look at the history of my patient. I'm going to look at where my patient is being placed in my organization. And if they're going to ICU or the renal ward or the hemato-oncology ward, I'm going to screen them without regard to their history, because if they have an outbreak in that area of my hospital, we're up the creek and the paddles are floating down the creek. So they're the kind of different approaches, but which of those you adopt is about understanding the risk to your healthcare organization and the resources in your healthcare organization. But you will have seen me slightly poo-poo it, but one of the UK SOPs I flashed up there was an algorithm of how to diagnose CPEs. There is a paired document that's free to access for anyone in the globe, a paired document with that, which is basically a menu that the UK HSA put out there that said, these are all the different options for how to screen for and diagnose CPEs. These are the ones that work better. Here's a positive predictive value. Here's negative predictive value. This is their cost. This is the amount of the proportion of the cost that's to do with the consumables. This is a proportion of cost that's to do with the man hours, acknowledging person hours are actually cheaper in some areas of the world than others, right? And that menu is gold dust, because it allows you to look at what's out there and say, okay, well, this fits for the patients I serve within the resources I'm given.
Okay, thanks, Luke. Yeah, really, really good answer. A follow-on question from Inez, which is a good one, thinking about the practicalities of decisions that you make around screening. And the comment really is that the AMR scenario is evolving. We are seeing more and more antimicrobial resistant organisms, and the demand for limited isolation space is increasing, and yet our hospitals are not evolving. So the problem is evolving, but our physical infrastructure is not. Could you comment on that?
As I pre-prepared this ground by saying, you two gentlemen are the built environments guys far more than me. Look, in the United Kingdom, we have something which is slowly in progress called the New Hospitals Programme. And other countries in the world are at different stages of understanding that threat, John, in that much of the infrastructure across much of the world is not fit for purpose for modern healthcare. And that's a little bit to do with volume and flow of citizens. It's a little bit to do with occupational therapy and physiotherapy needs, because we have a globally aging population. It's, to my mind, I know I'm preaching converted, a lot to do with infection prevention control and transmission events and avoidance of that. And as our understanding of transmission dynamics evolves, so our ability to engineer it out changes. But different areas of the world are at different levels of maturity. But I would argue, John, none of us are mature in our understanding of how to optimize the built environment to cope with AMR. Can we ever be, though? Because as you allude to, it's evolving. So our engineering and our built environment around hospitals has to evolve.
Thanks, Luke. It's a question from Naomi around diagnostics. And about, I guess, how we get more access to them. But in terms of availability of diagnostics, what do you think is the key challenge of certain like rapid point of care tests for helping us fight the fight against antimicrobial resistance? Do you think it's the availability or their integration within healthcare systems, or is there an economic argument around cost benefit analysis? What's the key sticking point at the moment why we're not using more diagnostics?
Different areas of the world, and those people who are online will see these different threats as being different. So threat number one is inability of lack of access, basically. But I would posit that's probably not true. I think there's certainly a lack of access to molecular diagnostics in some countries. Here in the UK, we don't have a lack of access to molecular diagnostics, but but access is an issue. The second problem, I would argue, is excess. So some people have gone in hard for molecular diagnostics for antimicrobial resistance, and that might be syndromic. Send me a respiratory sample and I will do some syndromic multiplex PCR and tell you what's there. Or it might be less in your face than that, but they don't deploy it appropriately. They use it on too many patients, and that then becomes a cost burden to the organization, but it also becomes a little bit like white noise to the clinicians receiving that data. And particularly with a lot of the molecular syndromic panels, unless you couple with that quite complex information, some kind of meaningful dialogue with an infection expert who knows what these results mean, then the poor old intensive care doctor or poor old respiratory doctor is going, what the blinking heck is an NDM versus an OX48, and why in this patient does it have both an NDM and a OX48? So you've got to have the right access without too much excess, and then you've got to have funding. And people always focus on the funding, and everybody in every country I've ever worked in hates business cases. Sure, I hate business cases, but the key to a well-executed business case is to get some kind of steer for what the funding is, then understand what parts of your service are no longer needed. So you take the funding of X and you say, okay, well, that's probably not enough. Hey, but look, I don't need to do this other stuff. It's just that you thought I did because we've been doing it for 20 years because we're humans and we learn slowly. You stop doing that. Then you add that amount to what the funders said. So now you've got a bigger pot. And then you go, okay, right. So I've got a bigger pot than the funders think. And then you go through how you're going to use this data, what you need. You go back to the people on the shop floor. Nobody ever should introduce a diagnostic without going back to the people on the shop floor. You go to the people on the shop floor and you say, what are the key threats to you? Right. So now you have your money. You know what the needs are. Then you do your risk assessment. You do your options appraisal using Katie Hopkins' Gold Dust UK HSA guidance on commercial carbapenem assays, and then using your money, your shop floor people's needs, and the menu in front of you. You as the infection expert can then make that. Right. That's all that's needed. It's not complex. Just take those three parts and put them together to make a wonderful dinner.
There's a lot of menus and food and dinner analogies today.
You can tell I haven't had lunch.
You're making me hungry. Okay, Lisa's taking us down a different angle, Luke, which is to think about our patients. And I think I was just reflecting that thinking about your comment earlier about terminology and the three or more letter acronyms that we use. You know, we're confusing ourselves as experts, let alone the patients for whom our language needs to be straightforward. But I think the point Lisa was trying to get across was more about education for patients as much as for staff. If we can get across good moments for hygiene following toileting, etc., and reduce use of things like commodes, then we can probably start to impact transmission.
Yes. So how do we précis and slipstream the messages we have to citizens and to other healthcare professionals? But this is a problem as old as time, I would argue. Ever since we've tried to shut water pumps with cholera in central London hundreds of years ago, right? We struggle with forming the right message. Now, we have really made our rod for our own backs with CROs, CPEs, CREs, VRE, GRE, MRSA, MSSA, CRAB, CPRA, haven't we? We like what on earth are we doing as a community? There's however many hundreds of us online here. We're not making our own job easy. What we need to do is stop that nonsense. What we need to do, and the reason I formatted my seminar in this way, is start with, you've got human cells, you've got bacterial cells. There's nothing you can do about that. Some strains of those bacteria are resistant to some of the antibiotics we have, some are not. If you've got those strains and there's nothing wrong with you, don't worry about it. But you've got to regress all the way back to the start of that story if you're going to bring patients with you on that journey. And so many times in clinic, I have patients coming in saying, I am resistant to antibiotics. as the first words out of their mouths. Can I see, you're the antibiotic guy. I am resistant to antibiotics. So there's something gone wrong in messaging here. But I would always argue the answer is start at the beginning of the story.
Yeah, we had a journal club with Julie and Claire recently, and we talked a lot about language in AMR and how, you know, sometimes we perceive it as this war and this battle, which it probably is, but sometimes I think that affects people's perceptions and their understanding of it potentially. One final question, Luke, if that's okay, and then we'll just share a couple of slides to close. This is a bit of a holistic one, but any advice for people who are thinking about trying to implement strategies to combat AMR in low income countries?
Yeah, it's a real problem. I feel for everybody trying to approach that. As with all of every single person's professional career, whether you are a healthcare professional or builder or an accountant or a mechanic or whatever, you can't solve a whole problem all at once. And the battle is actually about internal resilience, isn't it? I cannot solve antimicrobial resistance in the organization in which I am sitting right now. I cannot solve antibiotic resistance for the United Kingdom. I cannot solve antibiotic resistance for the globe. What I can do is work towards solving antibiotic resistance for the person in front of me, and to try and speak clearly and unequivocally to the other people working around me so that they can speak to the patients they serve in the same way. So my ask to you when you're in a low middle income country trying to address AMR, my ask to you is don't lose hope. My ask to you is don't try and address everything all at once. My ask to you is take the small wins. Solve perioperative antimicrobials. Solve sorting out the water on intensive care. Don't worry that you can't solve water in the normal care of the elderly wards. That's next year's problem. Take the small wins, stay internally resilient, and you know, we just need to work together. That's I don't have anything more complex, I'm afraid, Phil, than that.
I think that's really good advice. You know, small wins, and that importance about how we communicate across our organization and think about the problem that's in front of us and worry about things further down the line, you know, as and when we can approach them. Luke, been a pleasure as always. Thank you so much for such an interesting webinar. And we hope to see you again in the future. Just very briefly, before we finish, next week we've got a journal club. So next Wednesday, John and I will be talking about preoperative hypothermia and why we're still getting it wrong, which is in partnership with Solventum. You can scan the QR code there and that'll take you right through to the registration link. And that's Wednesday at 3 o'clock GMT. You can see all our schedules of webinars and journal clubs. This QR code will take you through to our website, so you can subscribe to make sure that you don't miss a journal club or an insight webinar. We won't spam you, we will just give you updates around events and blogs, all educational. And finally, we've developed these insight webinars in partnership with the Infection Prevention Society and the Healthcare Infection Society. So we always like to give some messaging to them. So you can join the IPC community and look at the events that are being showcased by the Infection Prevention Society. So you can scan but to look at all their events there. There's some fantastic regional study days, and we've got the national conference as well coming up in September in Leeds. So encourage you to get to that. Within the HIS community, we'd like to draw attention to the special interest groups. There's several of them, a lot of which I think are relevant to today's talk. We've talked about the built environment and BIPI. There's Spark as well. We're looking at wastewater and AMR. So something that's really interesting and growing a lot of attention at the moment. And then we've also got genotype, which is the use of genomics and how it can help our understanding of IPC and things like AMR as well. FIS as well. So this is a fantastic conference coming up in Glasgow in November, hosted by the Healthcare Infection Society. This is on the 24th and the 26th of November, and registration is open for that now. So please consider attending that. And also, there's another event for building safer hospitals. This is in London on the 9th of November. So November shaping up to be a busy month. This is to try and bring multidisciplinary teams together around the built environment, IPC leaders, construction and estates professionals, all around trying to tackle and build safe hospitals with this idea of AMR in the background. Okay, so massive thank you to HIS, the IPS, to John, and also to Luke, and we hope to see you next Wednesday. Luke, thanks again. Bye now.